2:30, so I think we'll start. My name's Iona and I help to coordinate the work of HCV Action. As many of you will know, HCV Action is a network of people who work on hepatitis C care, and we support the network by sharing best practice on our website and through events like these. We've been running webinars all of this week, and this is the final one in the series, but by no means the least. We're going to be hearing from a great lineup of panelists about supporting people who have traditionally been underserved by health services and face additional barriers to care. The session should last for around an hour, and we'll start by hearing 4 presentations, followed by a question and answer session hosted by my colleague Noah. If you have any questions as we go through the presentations, please write them in the Q&A box, and we'll go through them after all the presentations are finished. We're also going to be sharing the slides after the session, and that will include a write-up of the discussion that we've had in the session as well. So it's now my pleasure to introduce Beth Davies, Head of Service and Development at EDP Drug and Alcohol Services in Dorset. Over to you, Beth.
Thank you. I think I sent some slides over in the 11th hour. So yeah, I've been introduced. Can everyone hear me? That's at least on the panel. Okay, I can't see any of the attendants, so I can't tell whether they're waving their hands. I've put this together really in a rush, so please don't expect anything very polished from me. I'll tell you a little bit about why I think I've been asked to do this, because we recently got some money from the COVID response fund in Dorset, a local fund. There's similar ones all over the country. And the bid that I wrote and put in for, it's only £5,000, was for Gypsy and Traveller communities in Dorset. They are the largest minority group in rural Dorset, because we're, traditionally very South England and predominantly white British people. And that's been consistent, for quite a few decades now, that they're our largest minority community. So I suppose I'll dive in, run through my slides, and I can't ask the panel people or the participants, actually, because I didn't realise I wouldn't see any of them if they had any specific questions, so we'll leave that to the end. Go to the next slide, please. So I suppose, to state the obvious, when you're working with Gypsy, Roma, Traveller, boater communities, which is very little engagement with, they're a closed community. They're usually a satellite community. That doesn't mean, obviously, that there aren't quite large clusters of closed Gypsy Traveller communities in urban and suburban settings, because there's a lot of settled travellers. But I think that there's quite a number of initiatives with engaging those people, largely through their children who attend mainstream education. So what I'm focusing on here is more social satellites, people that either by choice or through long-term sort of being pushed to the edges and the outsides have chosen to live like this. You don't get education buses anymore visiting these communities, not in the south of England anyway. That stopped a long time ago. So if children are out of school, it's largely reliant on maybe social services, and really sort of proactive head teachers and stuff like that, trying to get people into school. We used to take education to them. It doesn't happen so much now. So I'm just sort of setting the scene that the main lever really would be if someone was old and dying in that community and they needed to get into health, or if someone was young and going to a local school. So it's quite limited. Our reach is quite limited, and it feels like there's not very much known about these communities, and they are extremely diverse. So if you can just think of it maybe in a tribal way, rather than you've got all Irish travellers are like this, all showman's folk are like this, all horse-drawn people are like this, because it really isn't like that. There's a lot of crossover between all those communities, and every single family or sort of transient group that move together, they've got really different norms and stuff like that. So you could do studies for years and still bowl up somewhere and it's going to be completely different. So you just might as well use common sense. So that leads me on to the sort of the risk bit. So obviously this is a sign, if you go back, go to the, this is a sign that caused quite a lot of discussion in the media and the public, because when it was first published, I think it was in The Guardian, there was a lot of, oh, that didn't ever happen. You know, there's nothing in the Irish history archives to indicate this ever happened. We've got no evidence that this ever happened. But I come from a mixed background, and I can assure you, having, you know, ancestors that are Gypsies, Irish, and travellers, this happened. This happened not only in pubs, this is meant to be a pub, but in local shops. I was excluded from going to the shop. It took a long time for them to know that I was living on a traveller community. But once they knew I was from that community, I wasn't allowed to go in, and I was 7. So I know these things happen. So just go on to the next one. And then this is another thing, I think this is probably from the 70s. And it's that classic 60s and 70s things where we're happy to import lots of people to do the work we don't want to do. And then when we don't need them to do the work, they're a problem, and we'd rather that they didn't bother us. So on to the next one. I'm not here to give a lecture on history or discrimination. So this is a recent statistics here, and it's quite shocking, and it might shine a light on why a certain politician was quite open with some of the remarks she made about Irish travellers very recently, because polls and the people that respond to anonymous polling indicated that, you know, 44% of people in England have negative attitudes towards Gypsy, Roma and Traveller people, you know, and so these are the poll responding people in this country. You know, I've been sat in lots of meetings, I've done very well, you know, for someone from my background, and it's not uncommon for people to put down travellers. It really isn't. And sometimes I bite my tongue, and sometimes I just silently loathe someone for quite a while. So, you know, because you can't see by how someone presents, you know, you get these sort of responses from people. I got it at school, got it all the way through my life. So, I mean, that sort of makes it obvious why I went for the money, because a lot of cuts in substance misuse services. And we had a great, when I launched the service here in Dorset, you can go on to the next slide, I had a great advantage in engaging a lot of people into drug treatment, because there's a lot of stigma around drug services, around healthcare. If you look at some of the recent health reports on those groups which have the poorer mortality rates, Gypsy and traveller communities, they get cancer, more prevalence of cancer, untreated cancer, sexual assault, domestic violence, all of these things largely underreported, you know, and we're sort of ill-equipped in our mainline services to deal with these things. And obviously, you know, when we go with all the goodwill in the world and with no bias that we're aware of, we're obviously met with really fierce opposition to receiving anything that we might bring to them. And because of previous experiences, and because people have chosen to remain in these lifestyles, because not everything about normal society is that appealing to them. So I think sometimes they'd rather do without our help and suffer a little bit and make their own way than take and accept what we've got. So this is the Hep C Trust drive that we did. We did a lot of work with engaging quite a few people. So it was a bit, you know, I don't know if you've ever heard of making every contact count. It's yeah. So off the back of the grant that we got, which was about engaging a lot of the traveller groups that had not been visited by any health services that we're aware of, the Hep C Trust were just so responsive, and they're like, we'll come and do this. So they just came and piggybacked in on the back of it. And it was actually wonderful, because a lot of the people that didn't want to engage with us for other reasons, for support with substance misuse and alcohol problems and those types of things, all came out to be tested. Every single person came out to be tested. And, you know, off the back of that, I was there on the day. There was a girl that was completely smoking crack cocaine in a caravan, and it took about 3 hours to get her out, to come out and unglue the crack pipe from her hand. But I managed to get her out of the caravan in the end. And we had like a really amazing intervention. And she's got into treatment. She'd recently had both her children taken off her, one of them while just after she gave birth to the child in hospital. She's full of self-pity for quite a while. You know, she couldn't really see her part in any of it. But it was, we managed to get to a real end sort of solution by the end of this discussion, and she's engaged in services now, which is wonderful. And she's, you know, she's started a methadone program. So it's ideal, you know, just sort of being creative. And, you know, next slide, please. I wouldn't say that I've got any real answers for anyone here. I don't feel like I'm that well qualified for this, but I would say that it's the basic stuff. So I'm probably reiterating stuff you know, and I'll round up now. You have to understand who authority figures are in any closed community or any group that you visit, obviously, because it's a condensed society. And so there'll be a much more obvious alpha, male or female, in that community, usually, maybe a couple. You have to be really assertive. You have to be really transparent, explain why you're there, what the deal is immediately, because it's very transactional, that way of life. So we have very sophisticated transactions that are all electronic, and they're going on all day, and we're just completely oblivious to them. But usually transactions with these communities are really direct and clear, and you can work, you know, if you're just authentic and just be really clear about what you can do, what you can't do, you know, and you can just be really, you know, if you think someone's maybe leading you somewhere and trying to get something that they want that you can't give, you're just really clear about it, you know. That's the only way that I found really works. You know, and the making every contact count. If you're managing to get some sort of engagement, whatever your background, monopolize on it. Please think outside the box, because the impacts are just exponential, aren't they? If you just get in there and think, actually, I can involve this person and that person, find out a little bit more than maybe just doing a blood test or, you know, talking about, you know, their sexual health or whatever it is. Avoid jargon, obviously. And, you know, just be a good listener. I think maybe for people that are doctors and stuff like that and used to general practice, those sort of very quick, you know, your listening isn't tuned in to that. Just, you have to give a little bit of space for these things. And if you've just achieved, when I went to the first news site with one of the drug workers to introduce them, when we first spoke to the guys on this site that is not engaged with any services, no one had a drug problem. By the time we left that site, they'd come to my car and they were taking naloxone, you know, a bin for clinical waste bin for someone that comes and visits sometime. That's fine. That's absolutely fine. If that's what you achieve in that, you know, that's wonderful. I don't know that I've got many more slides. I hope not. That's, you know, that's just obvious. We'll send that out with the slides for the people that are participating in this today. That's more about that, pushing that. That's more about that, pushing that. And that's it. Yay. Oh, and I've got a website there as well, which I can put up, which is wonderful, really wonderful website that covers all sorts of communities. They were the first on there with all the COVID stuff. It's got the policy on there. It's got people that are part of communities who are involved in the whole structure. So do check it out if you're unsure about anything, and they're really responsive. They managed to help us get skips to one of the sites and stuff like that. Really, really good. Highly recommend.
Thanks so much, Beth. It's a really interesting start to the session. I think with the Q&A, we'll wait until the end to cover those questions, but please write them in the Q&A box and we'll make sure we cover them after all the presentations are over. So I'm now going to pass over to Dr. Inês Campos-Matos, Head of Migration Health at Public Health England.
Thank you, Iona. Do you have my presentation? Yes, perfect. Thank you very much. So before we go on to the first slide, I just want to say, well, first of all, thank you very much for having me here. It's a pleasure to be part of this panelist discussion. I usually start these presentations with a long discussion about what a migrant means, what it is to be a migrant. I'm going to try to make it brief this time, and just would like to highlight that we all tend to mean different things when we talk about migrants. Some people say migrant and they think about people crossing the English Channel on a little boat. Some people say migrant and actually they think of anybody who is just not white British. Some people say migrant and they think about everybody who is born in a different country. It is, and the problem about migrants and public health and understanding the health of migrants is that in fact there is no set definition of what a migrant is. And some people move country and go back and forth, come over to work in the summer, for example, and then go back. They are migrants when they're here. That complicates things a little bit, but there are a few things that we do know about migrants. And we do know one thing, and that's the first slide, please. We know that the UK population, about approximately 14% of the UK population was born abroad. So that's usually how we identify migrants, is by where they are born. So if we imagine the UK population as this rectangle, the vast majority of people were born in the UK. That's the 86% in blue. But then about 6% were born in other EU countries, about 5% were born in Asian countries, about 2% were born in African countries, and another 2% in other countries across the world. And that includes the Americas, for example, and other European but non-EU countries. Now, this is quite a diverse population. Not many countries in the world have about 14% of their population being born abroad. But of these 14%, unfortunately, when we look at certain infectious diseases, the vast majority of them occur within these 14%. So next slide, please. So for example, over 70% of the cases of tuberculosis last year were diagnosed in people who were born abroad. Over half of the HIV cases, over 60% of malaria cases, and over 60% of enteric fever. So it's clear that for some diseases, migrants carry a much higher burden than the people who were born in the UK. Next slide, please. So what about hepatitis C? Well, we don't have a very comprehensive surveillance system of hepatitis C, but we do have a few data sources that give us a few indications. That's slightly deformatted, but I think people can see. So one of the data sources is sentinel surveillance. So that's a number of different labs across the country in which we look at the tests that they do for hepatitis C, and then we look at of those people tested, how many test positive and what their ethnicity is. So unfortunately, we don't have information about migration, but we have some information about ethnicity. And it shows that people of Eastern European ethnic groups are disproportionately affected. So overall, about 2.7% of the population that is tested in those labs has tested positive for anti-HCV, so test positive for hepatitis C. About 4.4% of all Eastern Europeans test positive. And a slightly lower proportion, 1.6% of people of South Asian ethnic groups test positive, which is interesting because the other source of data that we have is from blood donors. So we look at people who are the first blood donors for the first time, and we know that of every 100,000 blood donors, 3.6 will test positive for hepatitis C. But this is much higher, about 67 for people who are South Asian, and 66.6 in people who are of other white ethnic groups. Next slide, please. Another particular group of migrants that we know a little bit about is refugees. So refugees who are resettled in the UK, these are people who are escaping, most of whom are escaping the Syrian conflict. And they go through a very comprehensive health assessment before they come to the UK, which includes testing for a number of infectious diseases, hepatitis C being one of them. So we looked at people, all refugees who had been tested between 2013 and 2017. And there were about over 9,000 people were tested, and 38 tested positive for hepatitis C, which was about 0.4% of all this refugee population, which is still a bit higher than what we estimate to be the prevalence of the disease in England. And they were particularly high for people who were over 50 and who had a history of blood transfusion, so unsurprisingly. And next slide, please. Let's just highlight that. So if we go back to that rectangle of the UK population, and we see that the majority of people born in the UK and about 14% were born in other countries, and can you just click twice? And we imagine the burden of infectious diseases in this population. We can see that, first of all, that it is very, very small. If you look at all the migrants, the vast majority of migrants do not have an infectious disease. However, if we look only at the infectious diseases, some of them, and like the ones that I mentioned before, may be more common in migrants than they are in people who are born in the UK. Which is very complicated because it is a balance between stigma that migrants suffer because of infectious diseases, but also there is some vulnerability to these infectious diseases that we cannot ignore. Next slide, please. So why do migrants have an undue burden of some diseases? Can you just click twice more so I can have the full picture? Thank you. Yes, perfect. So there are three main groups of reasons, I think, that would can help us think why migrants can be so vulnerable to some diseases. One of them is related to their country of origin. So if a person comes from a country where hepatitis C or tuberculosis, for example, are very common, then they are more likely to have that disease. It's just, it's logical. If they come from a country that is poorer, with poor healthcare infrastructure, for example, if they were less likely to be able to access any kind of healthcare or vaccines or treatment, then they are more likely to be more vulnerable to some diseases. Another thing is the journey. So crossing the English Channel in a small boat will be very different from flying into the UK in your own private jet, as you can imagine. So the journey can have quite a strong impact on the health of migrants who come to the UK. There's something else about the journey as well that we often don't think about, which is the break of social ties. We all know how important family and friends and having your own social circles around you can be very important for your health, and that's your mental health. It's about getting access to information, knowing where to go when you have a problem. When a person moves country, they lose all of that support that is so important for their health. And that is quite important when it comes to the health of migrants. And finally, there's destination, of the fact that a person lives in a country legally or without the appropriate papers, if they live in a country with a different language, if they live in a country that has policies that don't allow them to access healthcare, for example, that all has a very big impact on the health of migrants too. Next slide, please. And so just to finalize, a very shameless plug of one of our resources. If you go on gov.uk and look for Migrant Health Guide, you will find this free online resource that we put together in the team. It is mainly aimed at primary care professionals, doctors, nurses, or any other healthcare professionals who see migrants in their day-to-day life, and it has pages that are dedicated to topic areas that may be relevant for migrants' health. It also has country-specific pages. So if you see a new person or have a new patient who is from a specific country, you can look, imagine from Argentina, you can go to the Argentina page. It will have information about language, culture, most prevalent infectious diseases and other diseases that you might want to be aware of when caring for that person. And can you please click on? So yes, and it has a checklist about assessing new patients who are migrants that might be helpful as well. So can you click through? It will just show a few examples of the pages. It has the gov.uk look. We can't get away from that, but I guarantee that the content is very interesting. And that is it from me. Thank you very much.
Thank you, Inês. That's amazing. Great. Really interesting. So now we're going to pass over to Amber Wilson, who's Business Development Manager at Basis Yorkshire.
Hi, I'm Amber Wilson. Such fascinating presentations already, and I'm learning a lot, but I've also seen quite a lot of similarities across the previous presentation. I work for Basis Yorkshire, and we support sex workers in Leeds. And the word stigma has come across already, and that's very much a theme that I think migrants face, gypsies and travellers face as well, which is possibly why I'm also part of this presentation, because we work with sex workers and we know that stigma is a real thing. We've been working in Leeds for nearly 30 years now, and it started up as a sex work project, but we now also have a young persons project. But the sex work is currently the largest element of our work, and we work with street as well as indoor workers. And in the indoor workers population, the vast majority of women that we do see are actually Eastern European women in Leeds. So we do recognise a little bit of what was said before about migrant workers as well. We work a bit with them as well. So maybe next slide, just to introduce a little bit about our work with Hep C and testing and treatment and things. So prior to 2017, we worked very closely with Forward Leeds, which is our harm reduction and recovery program in Leeds, and anybody that was obviously on script was asked about testing. We have a wonderful sexual health nurse who does testing with us. We'll go into the community, into people's homes, as well as do drop-in, and they're asked about all sorts of testing as well. Then so it was part of general engagement, and then in 2017 we were approached by the NHS Health Alliance to understand a bit more about how Access was working and how our staff engaged with it, and a bit more of understanding of where we were. And it got us as a team a bit more focused on the issue, I would say, and it was kind of it led us to kind of bring together a number of stakeholders. And we started off initially as a street project, because it is focusing on street women, but we realized actually we should include all sex workers in that, because there will be different barriers possibly, but still barriers for women to access their treatment, and some will be exactly the same barriers, whether it's street or indoor. So we started off by, we realized that we needed to improve access, and we needed to make this a concerted effort. Every year we do a very short, possibly not very scientific survey, but it is a survey that we do every winter, and it's primarily about health, just to get an assessment. And then it's a tool for engaging women on the subject of health, and finding any gaps in our or other services that are out there in terms of have we missed something. And that was one of the ways we identified that Hep C maybe wasn't being accessed as much as maybe it could be by the women we worked with. So we thought we'd need some more effort. And part of that was increasing the confidence of staff to engage on that topic, so having training. And we had the wonderful Hep C Trust in our offices, and they trained ourselves, but also Forward Leeds, who's our substance abuse service. And they have specialist workers that work specifically with sex workers. So they're trained, they were trained by us, but they're key workers, which is much more helpful for us to have specific workers on that topic. So we all were trained to have the same level of knowledge. And it's easier to have that kind of discussion by staff once you're trained and have a bit more of, we did a little practice session of what if women bring all these objections up, how do you handle that, how do you talk about it. As I said, we did our short survey to access it, and then we had a meeting with all the stakeholders, and so that was not only Forward Leeds and Sexual Health Services, as they were already doing testing anyway. And then we met up with a lovely team at St. James. I think there might be some people on the call listening now. And it kind of brought us all together in the room, realizing that we'd all been working with each other, but maybe not as directly linked as we could have been. And there we all were, and we were aware that there was a lot of misinformation about Hep C out there, particularly with women. We were aware that knowing each other and seeing each other, some of the staff knew them, some less so, that we would be able to have a more concerted effort towards it. And it was sometimes just about having that conversation, but more importantly, being in the places where women were. And where I have on the slide, I say improve the likelihood of access and build relationships with a liver nurse, for example. That's very much about what can we do to increase the likelihood that that will happen. So we have a drop-in, pre-COVID, we had a drop-in in our offices, and every other Monday, I think it was, a liver nurse would be there, so that if there was somebody that wanted to be tested, we could also have about Hep C, and whether she'd be in a room having a discussion with a client or whether she'd be out in the drop-in just having conversations, making tea, etc. People become familiar with you, the topic comes up, and we had quite a few people also just being tested because they happened to be there when the nurse was there. They hadn't booked an appointment, they were just there, the nurse was there, and then they thought, well, I did think about that then, but it never happened, and oh, why not? And you're having that conversation and thereby just being there. And they also worked really closely with the Joanna Project, which is another sex work project here in Leeds, who only work with street sex workers, and they have a drop-in as well. So there was a kind of a tag approach, like everywhere where they could. And actually, we also talked about possibly doing joint outreach on the street for a while. At the same, and we then also spoke to St James about the issues, and we talked about how what we saw as the issues were, and that might have helped them get some more funding. They got funding secured for 15 women to have specific treatment that would really reduce the time frame from testing to treatment. And we also then, at the end of it, kind of identified still some more areas that we should develop on. So a little bit of key success factors, what really worked? Well, I've said this before a little bit. It's like having conversations about Hep C, having the confidence to talk about it, understanding. So if you get a question back, particularly about challenging those myths, oh, isn't it really horrible treatment? Oh, is it really hard? But also saying it is, it is treatment that you need to consistently follow. It's a lot less hard, but you do need to consistently follow it, for example. But also letting them know we'll be there along the way for them. As I said before, being there on a drop-in or an outreach van, reminding, booking appointments, coming to appointments. We always, as much as we can, took women to the appointment. So we'd be there with them to support them, making sure transport therefore wasn't an issue. And then follow up with the team if there are any issues. I remember a specific case where I suppose if somebody's on a treatment, it isn't very hard to, it isn't, I don't know what the word is, but it's, once you're on the treatment, it isn't kind of, well, you can just stop and then start again. It's not quite the same as stopping a script. I gather this is due to the expense of the treatment. But we had a case where somebody had to flee their house quite unexpectedly due to domestic violence and exploitation. She wasn't able to take hardly anything, including her medication. So in that case, we also then have a conversation with the team. She can't make the appointment, but this is what's happening. Can we have, is this a reason to stop the treatment, or can we support her with that? And that was facilitated by the wonderful relationship we had with the staff at St James, who were really, really supportive. And yeah, that was really, really welcome. We already have a really strong relationship with Forward Leeds and Sexual Health. We have specialist nurses on both nurse for sexual health, but just workers Leeds that we work with. So it's a small group. We know them really well, and they know the women really well. So it's a familiar face. It's somebody they'll see in drop-in or an outreach, and it helps them to know that we know them as well. So it's a bit of an interconnection there. And it helped us, I suppose, this program was able to demonstrate the need for greater support. So if there's this push to focus on Hep C, we could demonstrate that through our intervention and being there and accompanying and having those conversations, it actually made a difference in getting women to treatment. There's still more work to do. We want to still do a little information pack for women about it. We do still have the question about Hep C on our winter health questionnaire. So we always ask women, do they know about it? What do they know? Do they need to get tested? Have they been tested? Would they like to access treatment? There's still, we have had some staff being trained to do some testing. At the moment, that's obviously not, but we have had quite a few bits of staff turnover, so that's something that either needs refreshing or doing. Evening outreach is something we need to really focus on. And one thing we never really got around to, but we have always talked about, is the peer-to-peer support. We have just set up an inclusion peer support small network of women. So that is something that we could work on with them to talk about things like Hep C. And I suppose we've got to the point where women who are on script or women who we engage with relatively well have been treated and do have the information. We know about it. We've been very successful there, but we do know there's a cohort that we haven't reached yet, and we still need to possibly work a bit harder to make that happen from our side. And it's one of those things where we just know that having a bit more information, but also being confident enough to discuss it and ask the questions, but at the same time, knowing that because we've had such a close relationship, once they get to the hospital, we know they'll be treated in a way that will encourage them to come back and continue the treatment has really, really helped. I hope I haven't rambled on too quickly. I do tend to do that, so I apologise. But thank you for listening, and I hope I'll be able to answer some of the questions in the Q&A before I need to leave.
Thank you, Amber. That's great. As I say, keep your questions coming in the Q&A box and we'll answer them all at the end of the presentations. So we're coming on to our final presentation, which is from Shabana Begum, who's the South Asian Project Officer at the Hepatitis C Trust. So I'll hand over to you, Shabana.
Thank you, Anna. Good afternoon, everyone. I've been at the trust, well, I was basically diagnosed and treated over 15 years ago, and worked about 5 years on a voluntary basis with the Hep C Trust, and with the trust now on the payroll for the past 10 years. I've had a lot of, as you can imagine, ups and downs trying to engage with my own community, but been successful at some point in some areas and continued from there. I myself, when I was diagnosed, I came across a lot of stigma. And with that, keeping that in mind, I try to engage with the South Asian community through routes, you could say, that I thought that would influence or held influence with the South Asian community. With the Hep C Trust, with Professor Foster, we put a project together. This was one of my first projects with the Trust back in 2010. And we devised a leaflet which had a perforated edge to it. It was handed out amongst a lot of mosques throughout the country, and especially started in London, and hoping that once we had gave the information to them before the mosques started the prayers on a Friday, that the participants or the mosque goers would take the leaflets, read the leaflet and tear the perforated edge off and take it to the GP for their testing. Apparently that did not work. It was very well publicised, but not a lot of people took that up. Then we started another project which was called the Hep Free Project as well later on, and engaged with different mosques in different areas and GP surgeries as well. Next one, please. Next slide. One of the first mailers I came across was the Bradford mailer. These are like, you could say, Afro-Caribbean festivals, but Asian ones, and are really well attended. They were held throughout the UK back in the day. Now they've cut down quite a bit, and this year, obviously, they've been cancelled. So we try and attend all the mailers, as many as possible. But back in 2010, the 200,000 people attended the Bradford mailer, which was over 2 days, over the weekend, Saturday and Sunday. We had the testing van there with us, and it was the first time we actually introduced mouth swabs, the OraSure ones, which were taken up quite keenly, actually, once explained what it was. 113 tests were done, and 4 people tested positive, which then obviously were encouraged and referred on to the hospital and the GPs. At that point, actually, we had devised a GP letter, which explained what we were doing and why we were doing it, and what the next step was for the GP to do, which was obviously the PCR testing. But then I got calls from GPs, that actually said that why do we need to test people, because these people that you have sent and they're saying that they're positive, they've not been back, they don't have any transmission routes, have not been back to Pakistan or India, and so we're not going to test them any further. So it was like going back to the drawing board again. Next slide, please. So obviously wanting to increase the hepatitis C testing and diagnosis for the ones at risk of infection, i.e. South Asians, which I was commissioned to do. We had to raise awareness and educate the HCP, so be it the nurses, be it the GPs, anybody that had any contact with the South Asian community or people would approach, we had to educate them. So it's like I said earlier, it was like going back to the drawing board and educating the GPs. So I approached public health as well in the same matter and engaged with them, and they said, yes, not a problem, we'll come on board. And it worked out well, because that way the message was going through public health, and as you know, it trickled down to the GPs, and then they were educated that way. But the main purpose behind it all was obviously to destigmatize it to the general public. So we did a lot of through the campaigns. We devised, I think it was a CD as well, that was handed out to mosques, which was a music CD. But then the mosque said that we are willing to pass on the message, which is a message related to saving saving lives. So, but could you actually come up with a CD with religious messages as well as religious hymns, and we did that as well. Next, please. Obviously, going through over the years, we're tackling with the issues with trying to find a way of engaging with the communities and trying to understand what it is that they understood from back home. So the word hepatitis C, they were not you could say enlightened with. They knew it as Kala Jirkan, which means black jaundice. So they knew what it was, and they associated it with like HIV and hepatitis B. So we had to make the message clear to them that it had nothing to do with both viruses, even though they are bloodborne viruses as well. But try to eliminate the superstitions and the taboos that they held. And those were the main ones. So they wouldn't talk to each other. They didn't want, if they had somebody in the family that had been diagnosed with hepatitis, they disassociated themselves. I mean, it happened to me. So for me, that was first-hand experience. So I took that on board, and that's why I approached the mosques as well. And any well-known person within the communities, be it the GPs or the imams or even the MPs, anybody that was from South Asian background that held some precedence, I would approach them and say, please, can you help me? So obviously showing them the benefits of being diagnosed and treated, that there is life after hepatitis C as well. Next slide, please. So came up with a slight snapshot, obviously looking into the South Asian communities and how the families actually run, you could say. Multi-generational households, average children that have 3 or 4. Family unit was very important to them. The information, advice would be shared, or we were hoping would be shared amongst the family themselves. And family members, we discovered, would be the motivators themselves within the family environment. Then you had the religious and the conservative people. Frequently they visited the mosque, other religious venues as well, and they observed religious practices. And they found it quite hard to talk about subjects, i.e. even about sex and drugs. They did not want to know anything about it, so it was complete no-no there. So we had to do a lot of work around that as well. And being from a South Asian background, they obviously had ties to their country of origin as well, very strong ties, and they made frequent visits. The communities here make them feel at home, you could say. You know, going back to Pakistan, it's like it's a must basically for a lot of the families, close-knit families. I mean, I myself was taken back in my teenage years, so I'd know what my background was. being South Asian, how you're supposed to, you could say, you know, how a good Muslim girl should be like. Basically, that was the training that was given in Pakistan as well. So it was a lot of people did go back home, but also because they are quite close knit, everybody wants to know everyone's business, you could say, in a way as well, in a nice way. And if, for example, I can give the example of if there was a suitor for a child in the family and they found out, oh, this person has hepatitis or some sort of disease, it'd be a complete no-no. So there was a stigma around that as well. So people had because they were close-knit, they'd keep quiet about it, not wanting to, you know, kind of save face in the community. Next slide, please. Through the campaigns as well, we had the Department of Health campaign, which was funded. Obviously, it was it ran for 3 months on 12 Asian channels. It did quite well. The feedback was very, very well received as well. Next slide, please. Staff training obviously takes place at the trust as well. I myself was trained up by Dr. Maria at BRI to do DBS tests because that was required, but we try and keep up to date with all the training at the trust. The bottom right, actually, going back, the bottom right actually is a picture of people that we actually trained up from the community that were quite prominent in the South Asian community in Scotland. We had 14 members, people that turned up. They then, next slide please, they then last year and the year before took part in the World Hepatitis Day, helped out at the mailers as well. So we had, you could say, trained up a cohort of volunteers up in Scotland, which have done a lot of work. Next, please. So part of my role was that approaching like Freshers Week at universities and colleges, putting up stands there, trying to educate the youth as well. I thought was really important. I even went to colleges as well, the social health care department, and they were very happy to take me on board. So I'd go into classes and educate the children or students about hepatitis C. Next, please. We had a variety of leaflets over the years that, I mean, you've seen the first ones, the green and white ones with the perforated edge. But then over the years, we've developed the literature, and this is the one that's now available in resources on the Hep C website that can be accessed, which is both in English and in Urdu. There's a link here that I've put in. I was part of a project, Understanding Hep C. It's a video, DVD, and which is downloadable as well if anybody needs access to it in Urdu and in English. So testing results, this is just a small example of what we've done. The testing at mailers, we sort of, I coordinated with Public Health in Manchester and the local hospitals and specialists as well there. And we put together pre-test assessment forms, which so basically we're at the mailer, we've got volunteers out with clipboards. They would be requested to fill in an assessment form and a consent form if they were wanting free tests, as that's how we promoted them, that we were offering free Hep C tests. And if you're interested, please come on board. So they'd actually fill in the pre-test assessment form and the consent form, and then they'd get the testing done, and they'd get educated on what hepatitis C was, the transmission routes as well. And then when they actually came back for the test results after 20 minutes or an hour, whenever they came back, they were asked to do a post-test evaluation as well, which was taken up quite well, and that actually showed whether or not the education that we were offering worked, and a majority of it, they did understand what it was, what the transmission routes were, they did remember, which was really good. You can see, I'll just keep it short, it was a 3-day event, because the mail itself takes place over a weekend, so that was the Saturday and the Sunday, but we actually joined it with a mosque as well, local mosque in Manchester, a very big mosque. The Heritage Centre took part in this testing, and we had we engaged with in the total of 377, from which negative was 200 and positive from 4. The undetermined, or the people that declined, 169 that declined, they still actually walked away with information, the leaflets. We would not let them leave until they had a leaflet in their hand to read. So findings and solutions, specific, I mean, obviously it had to be specific and targeted approach to the South Asian community, which was crucial. Being of South Asian heritage, I was born here, brought up here, was taken back to Pakistan for about 4 years, from which I actually learned, I think that obviously I learned how to approach the elders in the community. I would wear Asian attire, headscarf on the head, you know, so I was approachable by anybody, be it young or old. Then I discovered I can't do it on my own, obviously. I needed volunteers. So number one thing was rope in the family. And then people from the South Asian, people that I knew from the South Asian community, different genders as well. So both genders had to be including men talking to men, women talking to women, and people who were more approachable in that way. We also trying to keep it consistent with the clinics and the venues, the key venues that we were approaching, had to engage with the key stakeholders. So I'm part of an organisation which is called APPS UK, the Association for Pakistan Physicians and Surgeons, based here in the UK. Been associated with them for the past 10 years now, and they've helped me a lot on these events by sending out the doctors, or some of them are actually lecturers at medical colleges, universities, and they've actually thought it really good to engage the medical students, for them to be able to work at grassroots levels, and they really enjoyed it. So that was really good. Pathways, obviously, we tried the GP approach, which worked to us, didn't work to start off with, but having been educated through public health, they were quite approachable as well. And then having the Pakistani Association on board, massive help there, because majority of them are GPs as well. Then we actually obviously wanted to have a seamless, make it seamless and quite straightforward. So having the specialists on board took out the middle person, i.e. the GPs. So if somebody tested positive, the nurse would be there, specialist nurse would be there, or the specialist themselves would be there, and they'd take the patients on board straight away. So there was no basically losing patients in the pipeline, so to speak. Next slide, please. Right, I had a lot to say. We had a lot of slides, didn't we, Ian? But had to take a lot out. So basically, it's worked to a certain extent, but then again, of recent times, the South Asian testing has taken a back seat, and I would like to see it at the forefront again. So yeah, so basically it still needs to take place. People have been educated, and it's been quite successful as well. There's been a lot of success stories. Yeah, before last, when we were doing the Manchester mailer, just an example, I was approached by a couple, husband and wife, and the wife came up and hugged me, and she goes, "Thank you so much." And I just looked at her, trying to recognize, because obviously you meet so many people. I've met thousands and thousands of people in the past 10 years. You tend not to, you know, sometimes remember them. And I said, well, yeah, thank you, sister, for the hug, but how can I help you? And the husband came forward and he goes, "Sister, if you had not engaged with us and in a way forced us to have these tests, my wife would not be here today, because she had tested positive. And by the time she came to see me, she was clear, which was really good news. Obviously brought a tear to my eye as well. The job that I'm doing is worthwhile. We engaged with, we had funding from the Department of Health as well, 3-year funding. Just briefly mention this to yourselves. In the 3 years, with myself and the team of peers, we were actually able to engage with 4,500, over 4,500 South Asians. 36 events took place throughout the UK. 1,717 got tested. 48 were positive. And I'm pleased to say a majority of them did clear, which was really good news. hand on heart, I felt proud that we were able to save so many lives. I'm presently a patient rep and being from South Asian background as well. So I represent both, wear the two hats for the ODNs in Leeds and in Manchester is what the meetings that I attend or try to attend as well. Yes, that's about it. So any questions, please leave them in the inbox. I hope that wasn't too quick.
No, that was great. I'm going to pass over to Noah to run the question and answer session now.
Thank you.
Thank
Hi
you.
all. Just before we get started, I'll introduce Joan Coulton from Basis in Yorkshire, who is joining us for the Q&A from sort of filling for Amber. So the first question that's coming in is from Caroline, and it's aimed at Beth. The Scottish Government has recently announced a plan to fund some community health workers for Roma, Gypsy, Roma and Traveller communities. Do you have any thoughts on that? Do you think it's a good strategy to bridge the gap between statutory services communities, especially in relation to sort of health issues, especially those that might be stigmatised?
So just for my clarification, are we talking about health visitors visiting those communities?
So yes, yeah.
So extra money for health visitors, traditionally visiting families in their homes, you know, post having a child. Yeah, I mean, I think that the best way is to piggyback off the back of other services that have already got some engagement, and because it's so different, the picture and the funding streams everywhere, I wouldn't be able to guess the best approach for your area. I know that in some of the settled communities that are near me, for a long time there was a lot of mistrust with health visitors, maternity care and those types of things, and then in other areas they're the only people that they generally want to speak to the point where it's health visitors are trying to disengage and saying, well, you haven't got any infants anymore, and they want everything to go through them. So you know, I think you've just got to go with the people that the thing is with communities, as you'll know, any community, if there's a level of trust and rapport between a representative of a service, it will spill into the rest of the service, and you know, and you've just got to go off that because it's infectious in a good way. Yeah, and I would just say, you know, I know risks aside, you know, don't go anywhere with more than 2 people when you're doing sort of first contact stuff, and just keep it light touch to start with.
Fab, thanks. Now just sort of one aimed at basically all of you, and it'd be good to get all your thoughts on this. How has COVID changed the way that these communities sort of engage with health services? Because obviously in some sort of the general public, there's a lot of reporting about how people are engaging less with the health service, don't want to be a burden and don't want the risk of infection. But at the same time, we do hear occasionally that some people are thinking more about their health now, particularly infectious diseases. I don't know if any of you had sort of thoughts on that. Joan, would you sort of be able to start?
Yes, yeah, thank you. So we've found a lot of changes through COVID, and I think we expected, because we can't go out to do our usual 3 nights a week outreach, and because we can't open our doors 3 times a week for women to come to us, I think there was definitely a feeling on the team that we might have women disengage. And in actual fact, we found just the opposite, because we've been working so closely with our partners, including the police and Safer Leeds. We've found that a lot of women who've never engaged with services actually have started. And that has been around things like food parcels and emergency top-ups for gas and electricity and clothes and this kind of thing. But of course, that's where a relationship starts, as everyone here knows. You start out giving someone a food parcel, and then you find 6 months down the line that woman is actually engaging really well, that she's ready. And we've had this quite a lot over the last few months. We've had women who have gone from never wanting to engage with us to being ready to get into drug treatment. We've got women housed who've never engaged with us, and now they're housed within our Housing First scheme. They're on a caseload of 6. And then you can start then, once someone's got the basics that they need, you can start then with looking at that bigger stuff. We've got quite a lot of women going into counselling now, both through a counselling service in Leeds and through an in-house counselling service that we're just starting. And of course, that's where those conversations start. And I can really sort of nod along with everything that Beth was saying. There's so much that we can draw parallels with all our sort of very heavily stigmatized clients. And you don't start by going up to someone and saying, do you want to get Hep C tested? You start out with, you know, with having those sort of conversations and building those relationships.
Inês, I don't know if you have any thoughts to add on that specific question about COVID.
Just one very small thought that it also depends on the policies that were put in place. So, for example, what we saw for people who were sleeping rough or homeless, there was an everybody in policy, which really helped some people access care and testing when they never had before. And then on the other hand, asylum seekers in the UK have there's been quite a struggle to find hotels and places for people to stay when they have to, and so the effect was exactly the opposite. When they used to have some access, not great, but some access to some sort of primary care, they don't anymore, partly because of COVID. So it depended on the policy response or the policy response made a big difference in some cases too.
Thanks. Beth, do you sort of have anything to say on that?
Yeah, I mean, policy is everything. I mean, we're a subsidiary of Humankind EDPR in the south, and our policies, we worked through them with our clinical director and our person that oversees all the policies for infection control, and we came out with a very different offer than Humankind did during the lockdown. You know, we were still doing outreach, we were still doing deliveries, we were doing assessments on people's doorsteps. We had delivery drivers taking methadone out to people, and the Gypsy and Traveller work was a COVID response. You know, the film that you can see, the picture that you can see is the NHS Alliance and Hep C later guys out at the Traveller site with me. I think with an open mind and with some common sense, dare I say common sense without a policy number next to it, you can do pretty much anything. It depends on the people that you've got next to you, really. So yeah, I mean, obviously don't repeat that, but no, everything we did was safe, everything was signed off, and people just went with what they could do. They didn't say we can do this every day, but every day people woke up, got to work and went, right, what can we do today? I mean, that for me is what a risk assessment is. It's about, this is all the stuff we can do. This is the stuff that we definitely don't do. And usually you find that if you put it on its head like that, there's a lot more that you can do than you might realise. So yeah, I'll leave it there before I get myself in trouble.
Thanks. Shabana, is there anything you sort of want to add from your perspective and your thoughts on what's happened? I know it might be very different in different areas of the country.
Yeah, I think from the South Asian prospect, not a lot's been happening, obviously. Been talking to a lot of people that have had, unfortunately, a couple of people passed away this week as well from Hep C, so counselling them. But overall, I think the Hep C Trust has done immense work being with the peers. They've been going out there they've not stopped. From what I've learned, they've not stopped. Whereas I was in isolation housebound, they were out and about doing all the work, engaging with people on the streets, because obviously they were then being housed in hotels and it was easier for them to go in there and test them. So yeah, the Hep C Trust's work hasn't stopped, which is great.
Next question, just a quick question for Shabana. You use dry blood spot testing when you go to mailers and mosques?
Initially, we did the Orashow mass swaps, and then past couple of years we have been using the DBS test as well. Yes.
And do keep your questions coming in. If we don't get any others, I will just ask one sort of round-off question, which is if you sort of wanted someone who, say, a nurse in a practice or a service or a drug service worker to take away sort of 1 point from this, or one thing you think we want them to examine about their practice or their processes, what would that be? Just very quickly, does anyone want to go first? Shabana, I will go with you.
Just you mean away from this presentation that we've done today, from everybody being on board? I think it's excellent. I mean, it just shows the way forward, really. I mean, we've been doing a lot of Zoom meetings, and this has been really good way of engaging with everybody else and bringing up to date, of showing what everybody's doing in their own.
Oh, sorry, but more in terms of.
Sorry, go. I'm lost.
When someone to take something forward about the way they work on Hep C, for example, to make it more accessible to South Asian communities.
Right. Okay. I think a lot more GPs should be testing people for hepatitis within the South Asian communities as well. Maybe they could have like a marker to say, you know, at GP surgeries that you should, because obviously at the moment everything's being done over the phone anyway because of COVID, and it's quite difficult. But if anybody has symptoms, then yeah, they should get treated then somewhere or another.
Amber, I saw your hand go up.
Yeah, I mean, I'm sure Joan will say the same thing, but for us, a key word really is stigma, and how hard it is for, it's perceived or real stigma, and it actually doesn't make a difference, because at the end of the day, it's still stigma. And that stops so many, and it's often based on past experiences, but it has a huge influence how people feel about themselves. It's internalized stigma as well in terms of whether they will engage with that service. So anything you can do to break that down, to make it, to build that relationship and understand, always ask why as well. Why didn't somebody show up? Because they may have made an enormous effort to show up, but they didn't make it. That doesn't, you know, no assumptions, and understand the stigma and how hard it is for people to live with that stigma, even if you are not that professional that's stigmatized and they've got it around them. So I would say that would be a key takeaway for us. I don't know if Joan, if I've spoken in turn, but
no. I was thinking stigma, and also about coming to this with a trauma-informed approach, of course.
Yeah.
Thanks. Beth, you're next on my screen. Is there anything you'd say?
No, I sort of lost the thread there. I started replying to a question on the screen. What was the original question?
What's the sort of one thing you would want a nurse or a sort of service worker to take away from your talk? If you're going to give them one piece of advice you say they should follow, or change about the way they do things to make their service more accessible?
If you want to make your service more accessible, like I said, just be clear, really clear in your mind what your ultimate priority is there, but in some ways you need to throw that out of the window completely and not be so fixated on that you're just falling over yourself to try and get someone to do what you want. The best thing that you can get out of any intervention is for that person to walk away and think, actually, I think that person was really cool, I could trust them, don't really get what they're talking about, but you know, if they came down again, I'd go and have a chat with them. Because sometimes it's softly. The biggest influences for me in my life, you know, growing up in sort of really outlying, remote, random communities, were teachers that just had a genuine interest in your learning and growth, and that's very broad, isn't it? Because it's very person-centered. So it's hard for us guys because we've got stats and we want to get outcomes and we want to save lives, and it's wonderful that we want to do that, but sometimes we can get so caught up in trying to get it right and get our little box ticked and get our reports done that we forget that with people that are in small little bubbles of their own community, they've got other sort of ways of picking up your vibe, where you're coming from, and they're really good with social cues, and they're usually really savvy. So just go in there and just treat them like a human being, and you'll probably get much better results out of it. That's all I can say. And I was just replying then about the bit about the incentivization thing. The first thing I ever worked on was Bristol Drugs Project, and a sideline. It's called the 125 Project. It was a sex out worker project in a vehicle. And the best thing about that sex outreach worker job was that you just parked your van up at the side of the road, and all you were doing was giving someone a hot drink and a cake and a sandwich. And there was like quite a lot of Christian do-gooders, and then there was just quite a lot of people that just wanted to do volunteer work, but no one brought God into it. And it was all just about giving a woman time off the street to get warm and have a drink and a sandwich. And the outcomes from that project were just enormous. It could go anywhere. So, you know, just keep it real, keep it real, guys.
And people say it's just about chocolate, all you're doing is giving somebody a hot chocolate, but you're building a relationship, you're doing that thing, what you said right at the start about being that person they want to come back and talk to again. That's the reason why you're, well, not the only reason, you want to keep them warm and etc. But a key issue with our outreach is that you can actually build relationships.
Thank you both for your thoughts. Inês, is there anything you want to add on that sort of one thing to take away from today?
Yes, just one thing I think that was very clear through every presentation, but maybe just not always expressed in that way, which is just collaboration. We all work really, really hard, but we get so much more out of working with other people, learning from other people, but just joining forces. And sometimes we're in offices really close to each other, and we work on the same street, or we and we work for the same goal and for the same people, but coming at it from different perspectives. But when we join forces, I think we are much more than just the sum of our parts. And I think collaboration is always key in these interventions, from what I've seen.
Great.
And so speak to your local public health colleagues, because they're usually very, very good at collaboration.
That's great. Thanks for that. That's a good note to end on. Now I'll just bring everything to a close and just thank everyone who's come to speak. Thanks to Joan, Inês, Beth, Amber and Shabana. It's been really great to have you. And thank you all for attending. When you close this webinar, you should get a form opening asking you for feedback. Please do give that honestly. This is the first week we've run webinars like these, so we are really interested in what you think. Do let us know. Thanks very much. Bye-bye.
Bye.